Thank you very much for the invitation to speak at your meeting in Toronto, and I'm sorry I can't be here in person, even though I am here in your time zone. In terms of talking about extending the limits of heart failure therapy, I thought I would cover today extensions in the field of chronic heart failure, and particularly in heart failure with reduced ejection fraction, and go through the major leaps we've had with some drug therapies in the last few years. As well as thinking about extension of traditional blockade of the renin-angiotensin-aldosterone system, I'm also going to focus on some new targets we've had with former diabetic therapies, guanylate cyclase inhibitors, inotropes, and talk a little bit about the end, about a treatment of a common comorbidity in heart failure. In terms of thinking about what we're extending from, we've got to remember that the bar is very, very high for successful therapies for patients with reduced ejection fraction heart failure. And we're, of course, extending from the three cornerstone therapies, ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists, all of which have Class 1A evidence in any international guideline that you would like to cite, because these drugs, of course, in many trials over the last 25 years, have convincingly shown reductions in all-cause mortality, cardiovascular mortality, hospitalizations for heart failure, and they also improve symptoms and quality of life. So the first extension of renin-angiotensin-aldosterone system blockade that we had, of course, was a few years ago now with the angiotensin receptor blocker neprilysin inhibitor, sacubitril/valsartan. The extension is, of course, to inhibition of neprilysin. Neprilysin is the enzyme that breaks down natriuretic peptide hormones. Remember, these hormones are the good guys in heart failure, causing vasodilatation, natriuresis, and offsetting the augmentation of the renin-angiotensin-aldosterone system and sympathetic nervous systems that are in overdrive in heart failure. The sacubitril/valsartan, of course, was compared to enalapril in the seminal Paradigm HF study in over 8,000 patients with heart failure with reduced ejection fraction. And there was a significant benefit from sacubitril/valsartan over enalapril in terms of reduction in all-cause mortality, cardiovascular mortality, and hospitalizations for heart failure. There was a 20% relative risk reduction in addition to enalapril on the combined endpoint. That, of course, has led to the incorporation of sacubitril/valsartan in most international guidelines, and it's positioned in terms of a potential switch from an ACE inhibitor for patients who remain symptomatic with ejection fractions below 40%. So where might we be extending to? Well, there are two trials in the last few years that suggest we might be moving to using sacubitril/valsartan in ACE inhibitor naive patients. The transition study involving 1,000 patients, randomized patients to initiation and up-titration of sacubitril/valsartan in hospital versus post-discharge. And you can see that there was no increase in the potential adverse effects between these two strategies. The incidence of hyperkalemia, hypotension seemed to be the same, whether the drug was initiated in hospital or not. So it seems to be safe to do this. In addition, there was a trial carried out in the United States in just under 1,000 patients, randomizing patients to sacubitril/valsartan, comparing it to enalapril in hospital use. The primary endpoint was a surrogate one, which was a reduction in N-terminal pro-BNP concentrations, and you see those that were randomized to sacubitril/valsartan had a lower concentration of sacubitril/valsartan. They had similar rates of adverse events such as renal dysfunction, hyperkalemia, whether you were randomized to sacubitril/valsartan or enalapril in hospital. And looking ahead just to 8 weeks post-discharge, those assigned to sacubitril/valsartan appeared to have a reduction in hospitalization or mortality rates. So I think we will see from these two studies an extension of the use of ARNI or sacubitril/valsartan to ACE inhibitor naive patients over the next few years. But I suppose the real extensions to therapy concern really what to do next after your ACE inhibitor or ARNI and beta blocker and MRA if your patient remains symptomatic with reduced ejection fraction heart failure. And undoubtedly, the main steps forward have been taken by the trials looking at the sodium glucose cotransport inhibitors. You'll have heard much about these already at this conference in terms of their use in diabetes and chronic kidney disease, and I'm now going to turn to heart failure. The basis, of course, for using them in heart failure came out of those seminal studies in type 2 diabetes in patients with cardiovascular risk or established cardiovascular disease, where a number of SGLT2 inhibitors, 5 of them now to date, empagliflozin, dapagliflozin, canagliflozin, ertugliflozin, and more recently sotagliflozin, where we've seen that if they're started in patients with type 2 diabetes, these drugs seem to cause a reduction in heart failure hospitalizations. So this led, of course, to the seminal trials in heart failure with reduced ejection fraction. The first to report was the DAPA-HF study using dapagliflozin in just under 5,000 patients and comparing it to adding it to optimal medical therapy. And you can see there was a convincing result in this study with a reduction in both hospitalizations for heart failure and cardiovascular deaths. The interesting thing about this study is it was done in all heart failure patients with reduced ejection fraction, and the drug seemed to work whether or not the patient had diabetes. The adverse event profile was good between dapagliflozin and optimal medical care. There was, as you would expect, some volume depletion with dapagliflozin because of its osmotic effects on diuresis, but serious volume depletion was rare, occurring in about 1% of patients with dapagliflozin and similar to the placebo group. So the side effect profile, very good. A bit like London buses, we ended up with several studies coming along thereafter. So the Emperor reduced trial looked at empagliflozin in patients with heart failure and reduced ejection fraction. Again, all comers, they didn't just have to have diabetes. And once again, looking at the combined endpoint in this trial, empagliflozin significantly reduced patients' composite endpoint of cardiovascular death or hospitalizations for heart failure by about 25%. There were some differences in this study of just under 4,000 patients. The main effect was on reduction in hospitalizations for heart failure. There wasn't a reduction in patients in terms of cardiovascular death. However, very consistent results to dapagliflozin. And more recently, we've had data with the combined SGLT1 and 2 inhibitor, sotagliflozin. This time, the trial in heart failure was done in patients with worsening heart failure who were in hospital. And the drug could be started in hospital. And there was a reduction in this study with sotagliflozin compared to placebo in a composite endpoint of cardiovascular deaths, heart failure hospitalizations, and then urgent heart failure visits after discharge. So very, very consistent results from the SGLT2 inhibitors, showing that they improve hospitalizations for heart failure and cardiovascular mortality. And I'm pretty sure we're going to see these drugs getting Class 1 indications in the future for use in patients with reduced ejection fraction heart failure. But it's not just the SGLT2 inhibitors that we have to report on. In terms of other pathways, we're seeing trials now targeting different and non-neurohormonal pathways. And the first of those that I'm going to allude to now is drugs which interfere with the guanylate cyclase pathway. We've seen a number of trials in recent years targeting the end of this pathway using phosphodiesterase 5 inhibition, so drugs such as sildenafil and tadalafil, and they stop the breakdown of cyclic GMP. Cyclic GMP, of course, is responsible for vasorelaxation in heart failure. Unfortunately, these trials haven't proved very successful, but the alternative strategy of stimulating soluble guanylate cyclase does seem to have more promise. And we now have a large outcome trial in heart failure with a prototype soluble guanylate cyclase inhibitor, vericiguat, that looks promising. So the trial was in just over 5,000 patients, randomizing them to vericiguat versus optimal medical therapy. And you can see from the primary endpoint, which was cardiovascular deaths or first hospitalizations for heart failure, there was a 10% relative risk reduction for patients receiving vericiguat. The predominant effect here was on heart failure hospitalizations. There was no improvement in cardiovascular deaths, but definitely a positive trial and maybe some good news for patients with worsening heart failure. The next extension is, I suppose, a little bit of back to the future, looking at inotropes in chronic heart failure, a strategy that was abandoned about 30 years ago. But there is a novel inotrope which shows some promise here, and that is the cardiac myosin activator omecamtiv mecarbil. Omecamtiv promotes actin-dependent phosphate release and moves the cross-bridge between actin and myosin into its strongly bound force-producing state. Phase 2 trials with this drug show that it is an inotrope. It increases systolic ejection time, but it does not seem to increase heart rate or myocardial oxygen consumption. It's now been tried in a large outcome trial in patients with heart failure and reduced ejection fraction of just over 8,000 patients, the Galactic study. And again, looking at the primary endpoint here, there was an 8% reduction in the composite endpoint of time to first heart failure event or cardiovascular deaths with this drug. Once again, it also didn't reduce cardiovascular deaths. But again, an exciting development and something perhaps new to think about in the future. I want to end just by thinking a little bit about moving and extending therapies from targeting just systolic dysfunction to comorbidities in heart failure. We know from the epidemiology of heart failure over the last 10 years or so that the average age that patients present is increasing. And this is a study from Oxford in the UK from a few years ago now, showing that the mean age of presentation in the UK is now 77, and that's increased from 76 over the last decade. And patients are presenting older with more frequent comorbidities. The average number of comorbidities is now 5. And they are by no means insignificant. About a fifth of patients have anemia, a fifth have cancer, a quarter have chronic kidney disease, a fifth have diabetes, and many others with stroke, dementia and frailty. So these are important potential targets for the future. In terms of evidence for treating comorbidities, the best to date comes from the treatment of iron deficiency anemia and iron deficiency with intravenous iron. There were 2 small studies, FAIR-HF and CONFIRM-HF, published a number of years ago, showing that treating iron deficiency with intravenous iron, whether or not patients were anemic or not, led to improvements in effort capacity and quality of life. This now has led to a large randomised controlled trial looking at harder outcomes in patients with reduced ejection fraction heart failure. The trial HFrEF was published in November last year and looked at the intravenous iron product ferric carboxymaltose in patients who had been hospitalised for heart failure with reduced ejection fraction who had iron deficiency. They did not have to be anemic, they just had to have iron deficiency. And you can see, looking here at what happened subsequently, the trial was at just about 1,000 patients. At 1 year after randomisation, heart failure hospitalisations and cardiovascular deaths appeared to be reduced by about 21%. And the predominant effect here was on a reduction in heart failure hospitalisations. There was no improvement in cardiovascular death. So again, some hope here for the future that treating comorbidities might also confer some benefit. So where are we after these extensions of heart failure therapies in reduced ejection fraction heart failure that we've seen over the last few years? Well, if you look back over the last 30 years, of course, we've seen massive improvements in mortality for heart failure patients in NYHA class 2 to 3 heart failure with reduced ejection fraction, with the serial addition of ACE inhibitors, beta blockers, MRAs, cardiac resynchronization therapy, pacemakers, ICDs, and now we can add to this sacubitril valsartan, SGLT2I inhibitors, and soluble guanate cyclase inhibitors. So we've made a lot of progress, and hopefully we're driving that number down in terms of annual mortality all the time. This, of course, is in clinical trials, and we have to see these drugs, of course, translated into real-life scenarios of reduction in adverse outcomes for our patients. We mustn't be complacent. I'll leave you with this last slide from London. There is still a huge evidence gap in heart failure. We probably have a residual mortality risk and recurrent cardiovascular hospitalisation risk of somewhere between 12 and 20% that is perhaps modifiable by future drug and device therapies in the future. I'll stop there.